So thank you so much for the opportunity to speak to you today. It's truly an honor to be able to do this, and also my pleasure to share some of the population health research that NINR supports that I've been overseeing for the past year and a half. So my icebreaker, I'm going to start with a question. What's our biggest challenge to improving the overall health of the U.S. population today? So just something to think about while I'm giving my talk. It went by accident. So in my talk, I'll present a number of population research projects that have been supported by NINR in a number of contexts around the world. Through this, I hope to demonstrate that improving the health of a population in any country involves similar challenges to what we face in the U.S., and that working in partnership and sharing strategies is a win-win situation. So I'm going to start with some background on NINR engagement in population health, including support for global nursing science. I'll talk some about what it's meant by population health, or what I'm meaning by it. Then move on to discuss several projects in detail. So the first set of projects are going to be around MCH, or maternal child health, and the second set will be focused on HIV. And for the HIV projects, I'm going to also present some background just to kind of catch people up on what's happening with that epidemic these days. And then finally, I'll end with some currently active projects that address research gaps and future directions. So NINR supports research to improve the health of diverse populations within the U.S. and across the world to achieve its mission of advancing nursing science to improve the health and well-being of the world's citizens. NINR provides global support for nursing science in several ways, which we heard from Dr. Katz. First, it supports training through the Medical Education Partnership Initiative, or MEPI, that is designed to build clinical and research capacity. NINR has also participated in the Human Heredity and Health in Africa, or the H3 Africa initiative, which aims to build capacity for the study of genomics and environmental determinants of common diseases in Africa. In addition, our director meets with her nursing counterparts from other countries and regions who have an interest in building nursing science capacity and alliances. And I had the opportunity to witness her experience firsthand last fall when she met with a group of nurse scientists from South Korea and their diplomats. But of course, the biggest way that NINR supports population health research is by providing awards to scientists. So population health could be defined as the health outcomes of groups of individuals within a population. We know that outcomes can be very different for different groups. If we add the global health onto that, it expands this concept to include health issues that transcend national boundaries. So this list, maternal child health, infectious disease, non-communicable diseases, and end-of-life care, are all areas that NINR's population health research addresses, both in the U.S. and abroad. But most of NINR's current global health portfolio is focused on HIV and AIDS. So why is that? Well, there was a seismic shift in global health in the years following the AIDS epidemic, pandemic. There was the devastating impact of HIV on populations throughout the world made HIV response critical. I mean, whole populations of adults were dying. More global resources went to combating HIV and AIDS, and this was bolstered by the President's Emergency Plan for AIDS Relief, which came out in the early 2000s. So a lot of resources went to AIDS. So before I discuss specific examples of NINR's supported work in population health, I'd like to mention a few essential components that make a population project more impactful. Okay, first of all, cost effectiveness. Public health interventions in the US or anywhere in the world have to be cost effective to be sustainable. Okay, number two, and this is going to belie my background as an anthropologist, studies that account for sociocultural context up front in their applications have a big advantage, and I've seen this through review as well. Anthropologists, sociologists spend years in the field figuring out how populations are functioning. You know, the social, the cultural conditions, how people understand health and illness, and so on, right? People who are doing global health or population health projects, especially if it's an intervention, do not have that luxury of time. And so, you know, you get a head start by including this literature, reading it. It might not be in PubMed, it might be somewhere else, but it's a big advantage to use that research. It's a big resource that is often not used. So number three, successful projects include local partners at every stage of the research. So local partners ensure buy-in, and buy-in is critical for sustainability. Okay, so now I'm going to move right along to my first finished project, NINR project. It was an R03 that focused on child health in Guatemala. So the second leading cause of death among Guatemalan children is diarrhea. Among indigenous Guatemalans, they make up 80% of the population of Guatemala. The child mortality rate is sadly over 18% for children under 5. Indigenous Mayan, who make up the majority, are very poor, with per capita income of just over $2,800 US per year. They receive, on average, 2 years of schooling, and Indigenous women have lower levels of health literacy than the men. So Dr. Roxanne Amerson and her team sought to address this problem by developing a curriculum to train community outreach workers called promotoras with oral rehydration therapy, which is basically water, salt, sugar mixed in the right proportions. In this case, it was an added zinc supplement. And to train them to use it and to train other women in the community to use this when their kids had diarrhea. So they tested this curriculum in a group of women. They learned a lot through training the women, including about the concept of simpatia, which is translated as the value of smooth, pleasing relationships that avoid conflict or confrontation. So in order to respect this, and stay aligned and on good terms, they didn't provide direct feedback in a classroom context. They also kept everybody in the training, even though it was apparent they weren't going to be able to pass the test or function as a promotora. They also learned that written materials were not feasible for the training in this context. Their conclusion outlines 10 specific recommendations on implementing training in this low literacy context and 4 strategies for teaching and tracking procedures that don't require reading or writing. So these suggestions, I will hazard to guess, would be very applicable to some groups that I've worked with in the US who are not oriented toward the written word, but are much more orally oriented. So next, I'd like to turn your attention to an R21 project that focused on antenatal care in Malawi. And this is my favorite project. NINR supported a pilot test of an antenatal care strategy in Malawi called Centering Pregnancy. This strategy was developed by a Yale professor of midwifery, Sharon Rising, in the mid-90s. The basic idea is to empower patients and strengthen relationships and communities. So how do they do this? Rather than assessing blood pressure and measuring belly girth and weight one-on-one with a provider like you see in the first picture, these activities and assessments are done in a group, in a circle. So in addition to these assessments, they also do the training, prenatal care, health education, and then they also will talk together with women and problem solve any issues that come up in their pregnancy. This ANC model was highly effective in clinical trials in the US that were over 1,000 women. They found a 33 to 41% decrease in prenatal or preterm birth. And this was especially true among the under-resourced women that were participating in the clinical trial. They found increase in condom use and decreased pregnancy at 6 months. So an American and a Malawian team piloted this CP plus with an added HIV component in Malawi. They used action research to iteratively incorporate input from health ministers, local practitioners, Centering Health Institute staff in the US, as well as pregnant Malawian women. The sessions were translated into Quechua, and then they tested it in a cohort of women. The takeaway is this was feasible. It met both in-country practice standards as well as CP standards in a low-resource, low-literacy, high HIV setting. And this is the first study, believe it or not, of this kind in sub-Saharan Africa. A midwife said, "I was surprised by their ability. Today I found out that the women were capable and eager." And the women themselves were so appreciative that they wrote a centering pregnancy song, which is published in the article. And I won't try to sing that. So NINR recently awarded another R21 to another team to conduct a controlled trial of centering pregnancy, replacing the HIV with a weight control component. And they're going to conduct this trial in American Samoa, which, as you may know, has a population with the highest percentage of obesity of any US population. Sorry, allergies. So the next set of projects that I'm going to talk about now will turn to AIDS. And I'm going to preface these with just a bit of a background on what's happening in AIDS these days, a little bit. So in 2015, the UN-AIDS established new targets, which everybody's probably heard about, that they hope will bring an end to the AIDS epidemic. So what I like about these goals is that they're stated from the perspective of the person. So they are 90% of all people living with HIV will know their HIV status. 90% of all people living with HIV will receive antiretroviral therapy, and 90% of all those receiving therapy will have viral suppression. So most of NINR's HIV portfolio is located in the US. So how is the US doing on these figures? So this slide shows how the US in green compares on the 90 targets. Global estimates are in red, Europe and North America blue, and Botswana in purple. In the US, as many of you know, HIV and AIDS is most prevalent among gay and bisexual men, white, Latino, African American, with Black MSM bearing a disproportionate burden to the, relative to their numbers in the overall population. New infections are highest and kind of scary among minority MSM ages 13 to 24. All groups of heterosexual women are impacted, with Black women bearing the greatest HIV burden. So how is the US doing on testing? It looks like we're pretty good, except that 87 number really means that 1 in 8 people with HIV don't know their status. Prescribing ART, the US falls to 37%, lower than the global estimate and much lower than Botswana, who reaches 76 of their HIV-infected populations with ART. The US is very poor on virus suppression compared with others. Botswana, for example, does a really good job of retaining people in care and ensuring viral suppression in their HIV-positive population. So why is it so important for everyone to achieve and maintain viral suppression? Well, findings from the HIV Prevention Trials Network 52 found, besides being our best opportunity for improving health outcomes, and it really is, Early antiretroviral therapy also reduces HIV transmission by 96%. So now ARVs are prescribed immediately upon diagnosis. They don't wait for the CD4 to fall, which CD4, as many of you know, is the measure of T cell functioning and immune health. So in 2014, clinical guidelines for an important new tool to prevent HIV transmission was rolled out. Pre-exposure prophylaxis, or Truvada, its brand name. It's a single pill taken each day. It was found to be 97% effective in preventing HIV transmission. Now that's if you take it perfectly. We know people aren't perfect, especially when it comes to taking medications, and I know for sure that I'm not. So this is a nice segue to move into the next area that I'm going to focus on. I'm going to did I not? Yes. To the next project, I'm going to present. We'll address ART adherence. So I'm going to preface this again with some background on HIV-related stigma because it's a powerful factor in ART adherence. The concept of stigma, first written about by sociologist Irving Goffman in 1963 in Stigma, Notes on the Management of a Spoiled Identity. This is required reading for any sociology, anthropology grad student. This concept of stigma was picked up by the HIV/AIDS researchers early on in the PEPFAR initiative, which started about 2003 or so. I was working for the Demographic and Health Research Group at that time and participated in USAID-sponsored stigma work groups and just saw the stigma research take off. So what was learned is that HIV/AIDS-related stigma and discrimination heavily influences whether or not someone gets a test, whether or not they adhere to their medications, whether or not they engage in care at all. And we know it's critical for this group to engage in care over the long haul, not just to prevent disease progression and prevent transmission, but also to deal with all of the co-infections, comorbidities, everything that they're going to experience more than your general population. So stigma is spoken about at the at the social interactive level and at the individual level. This diagram illustrates the pathways through which stigma is internalized, whereupon the negative feelings associated with the disease are assimilated and they threaten self-esteem. This is where you find people just giving up on themselves. Researchers have found that the stigma trajectory, along with physical manifestation of disease, must be managed over the life of the illness to have good health outcomes and good quality of life in this group. So, and also, by the way, stigma, when I Googled for a diagram on the internet, it's gone viral. It's like stigma is now applied to obesity, and it's applied to everything, you name it. They're taking advantage of this concept in this research. So now I'm going to move to the study itself, which is a technology-based strategy developed and tested in our 21 study to manage this stigma trajectory. Julie Barroso and Michael Relf developed and tested a stigma reduction strategy delivered via iPod Touch to women living in North Carolina. They produced a 45-minute video that was based on an exhaustive review of the HIV stigma literature, specifically as it's related to women. And they came up with these 5 different scenarios that were part of this 45-minute video. They recruited around 100 women, screened for medium and high levels of generalized stigma. The sample was urban, rural, low income, mostly African American in North Carolina. And they didn't tell women how often to watch the video. They tested their response over a 12-week period. And what they found is women were able to use the iPod Touch with minimal assistance and with minimal need to replace the unit. Women's HIV status remained confidential throughout the trial, so no one was accidentally outed. Those receiving intervention watched the entire video on iPod 9 to 10 times over a 12-week period. The videos were rated on narrative transportation and perceived realism scales, so the video was compelling and real to the women. It included modules designed to help with HIV disclosure decisions, which is a decision, and also with depression, which are two factors that heavily influence ART adherence. So from a measurement perspective, they found a 0.81 effect size on internalized stigma for the people in the intervention group. But, you know, better than the numbers were what women said. These quotes captured how powerful these scenarios were for the women and why they watched it so many times. And you can see that they've had been HIV infected for a long time, most of them. I really like this second statement where she says, "I'm getting closer to myself. I'm not as much on eggshells as I was. It's given me some unimaginable relief that's hard to put in words." So to summarize, the disease-related stigma leads to marginalization of groups, and here we saw an intervention that addresses the issue and empowers those that are afflicted. Okay, so now I'm going to turn to advanced care planning. Advanced care planning is a process mostly started for individuals with life-limiting illnesses, chronic illnesses. It helps to reduce stress for the surrogate caregivers and protects patients' autonomy at the end of life. So really, it's an effort to start the conversation about these hard decisions that are going to happen earlier with caregivers, with providers, so that the wishes and desires are known and respected. So Dr. Maureen Lyon and her team have tested the family-centered, or FACE, you may have heard of, advanced care planning strategy in other groups, including patients with cancer and with end-stage kidney diseases. They're now bringing this efficacious intervention to people living with HIV. They recruited around 222 dyads from 5 hospital-based outpatient clinics in DC. They implemented the intervention, which is conducted in 2 sessions. At this point, we just have the baseline results, but they found significant differences between the African Americans and non-African Americans. The top difference was the importance of comfort from church services. So most of them identified themselves as traditionalist or very religious. And this group reported better quality of life in terms of social support and self-esteem than non-traditionals. So therefore, assessing a patient's spirituality or religiosity may inform providers as to the patient's quality of life and help them identify areas of need. So the takeaway to date is that African Americans are willing to participate in advanced care planning. Okay, I'm almost done. I know it's right before the break, so finally, I'll end with some currently active projects that address research gaps and future directions. So first, I'm going to do that by way of a few funding announcements that we have out that are related to this area. So the first 2 up here are published by NINR, and they're both HIV related. The second 2 are published by other institutes. The third one down is published by the National Institute on Aging. The last one by the Fogarty International Center. And we have shared interests in these FOAs, so NINR has signed on. So, all right, so now I'm going to talk about some of the current things that are ongoing in my portfolio and how they address gaps. So the first big gap is these new infections that are occurring among young minority MSM. One of our PIs, Ron Stahl, and his team are in the final stages of an R01 that's focused on understanding delayed access among this group. He's currently recruited almost 5,500 Black MSM by going to gay pride parades around the country over the past 4 summers. He is conducting this in concert with another PI who is doing blood spot tests on, which it's a new technology. They can get HIV, CD4, viral load, and ARV in the blood just by a fingerprint prick. So they're also now collecting this information. So we're really excited to hear, what they're going to find out about these populations. One of his team won first prize for an early stage investigator paper based on this work, and this at the International AIDS Conference in Durban. And this paper was chosen out of like more than 5,000 papers, which, how does that happen? Anyway, the next gap area, currently there are very few, believe it or not, efficacious adherence intervention for adolescents. These are people that have a long life ahead of them. It's super important. NINR recently funded Matthew Mimiaga and his team to use a staged intervention to determine the most impactful, promising intervention components that help young people living with HIV stay on their medications. And then probably the gap area with the most potential for accelerating positive impact on population health is the science of understanding how to reach these specific groups. NINR recently awarded an R01 to Steph Baral and his team to test a nurse-led HIV treatment and retention intervention for high-risk women living in South Africa. So he's using a SMART study design, which is an implementation design, to reach women who are positive to improve viral suppression. And this group, they recognize that a single intervention doesn't work for everyone, so they have a bag of 3 to 4 interventions, and these are rolled out to women only if they don't achieve viral suppression with the previous component. So this is efficient and staged, and so we learn what works for who and why. So we're very excited about these projects. So as Flora Katz was mentioning in her slides, the future direction for population health. Globally, we now have a better handle on infectious disease. Malaria is way down, TB is down. It's mainly a problem in relation to HIV co-infection. But what we're seeing is the rise, or maybe it's been there all along, chronic diseases such as metabolic syndrome, diabetes, CVD, hypertension, and so on. So currently, NINR has one project that addresses the growth of non-communicable diseases in low and middle income countries. This is a self-management education intervention using an M-Health strategy that's being tested in Mexico City. So in conclusion, I want to say our major challenge, whether we're talking about infectious disease or chronic disease, is the same. We know what to do. It's how do we do it to ensure that everyone benefits. The future is understanding these variations in needs and specifying strategies that are going to ensure that we reach everybody. The world is getting smaller. Every day, strategies that work in one context may be the key to unlocking and reaching specific groups in another context, and vice versa. So the global approach to population health is critical to reaching everyone, especially those that are not now benefiting from the science and tools we know improve health, well-being, and lives. Okay, that's it. That's all I have to say.